when Greg asked me what topics I would like to discuss, one of my favorite things to look at is like how much sinus surgery is necessary, right? So I am what people call a big hole guy, right? So I do a lot of big holes for people with bad chronic inflammatory disease. I have a tertiary practice. I see people all the time with multiple surgeries and everything. And, one of my philosophies is like if I want to make it their last surgery a lot of times. But the question is, do you have to do big holes all the time? And what's the scenario? What's the underlying disease process? What drives their problem, right? And so I put these up here because these are 3 different phenotypes, right? A physical expression of an underlying problem. And the physical expression here, in the right side, you've got probably looks like a fungal ball causing problems. Maybe you won't see any bad teeth there, but there could be a bad tooth. In the middle is the classic allergic fungal sinusitis. And then you've got a chronic eosinophilic rhinosinusitis on the right side. Sorry, messed up in there. So on the right side. So different phenotypes, and they might respond differently to drugs. They might respond differently to the way you manage them, and how you do things from a surgical standpoint. I mentioned this yesterday. I really like the EPOS 2020 description of the way that we kind of look at endotype dominance and clinical examples or phenotypes. And it's just divided into like that type 2, non-type 2 type of etiologies. And at the top, you've got, a localized type thing with allergic fungal sinusitis or rhinosinusitis, where you've got perhaps like 50% are one-sided or unilateral, for example. But they also can be bilateral. You get the non-type 2, which is going to be like a OMC. You can have odontogenic type sinusitis, which is non-type 2. And then the type 2 is like the central compartment disease, the ECRS, the AFRS. Really nice way to think about it. And then the secondary CRS is going to be those things that cause problems from an underlying process, like cystic fibrosis causing a genetic problem, a fungal ball causing obstruction, and secondary bacterial infection. And so these are some of the things that we think about when we see these patients and trying to figure out, okay, what is the best way to treat them? And so here's like my first question for the panel. I've actually gone to doing more lab work up front. And as a revision practice and a tertiary practice, you get a lot of people who've had multiple surgeries and whatnot. And I find a lot of them haven't had a decent panel of lab work. And so the 3 of us, my rhinology partners as well, have gone to a kind of standard lab work protocol. And so it's predicated on a number of different things. One is, you have that N of 1 who influences your future practice. I'm sure you guys have had those as well. And I had a lady with a fungal ball in the sphenoid, very straightforward. She had 2 surgeries, and I was like, oh, the reason this didn't work is they didn't have a sphenoid drill out and whatnot. And I go ahead and do the sphenoid drill out, and all her sinuses just go to crap. She has tons of infection. Oh, well, it turns out like her IgG was 400, right? So, and I didn't know that up front. And so in the future, like every time I see one of these patients, I'm like, okay, well, I'm going to check everything up front, because if I had taken that patient and sent her to immunology and she had been on some IVIG ahead of time, probably wouldn't have had that problem. And now she's got persistent infection problems and everything. So, and the other thing is about CF genetic screen. So I've done that as part of my research, and there's a quick Quest genetic screen, and I don't know if you guys know about CFTR-related disorder, but heterozygotes actually have more incidence of chronic sinusitis. So this is my lab work, and then I consider autoimmune labs for different workups. Consider ciliary brush biopsy, especially if they got bronchiectasis and haven't been diagnosed with CF. From the panel standpoint, what kind of lab work do you do up front? Do you do lab work up front? Do you wait until they have a problem?
We get a similar panel. Do you want me to hold this up?
Yeah. Sure.
We get a similar panel with some tweaking. If it's more infectious, then I think about immunodeficiency and get the immunoglobulins and maybe subclasses. We also have, through Mayo Medical Labs, I get no benefit from that, urine leukotriene levels for aspirin, exacerbated respiratory disease screening. It's not perfect, but the level of the urine leukotriene level does associate with the likelihood of AERD and the severity of their disease and the symptoms, so we use that. My resident said, boy, you do a lot of medicine in your clinic, Dr. O'Brien, and that was not a compliment. But they didn't enjoy that. They're like, let's operate. But we do this. I think we should standardize this, I think, across the specialty, because we have got to endotype these better. And I like this list, but then I look at, like you said, bronchiectasis, immunodeficiencies. How much is your CF gene screening test? Do you know?
How much? I think it's like $90, $95.
That's not bad.
Yeah, and I believe, so I actually, part of my basic science work is related to CF and looking at CFTR modulators and non-CF disease. But as part of a protocol for looking at one of these CFTR modulators in people with non-CF chronic sinusitis, I did CF genetic screens. That's why I was like, this test study isn't that expensive. I should just get this every time. And so that was a really good way to do it.
I love this question because I feel like it's more and more, and we've seen tested that in some other talks today about how rhinology is becoming, you almost have to be part immunologist or part allergist to be an effective rhinologist in 2023. I've learned a lot from Drew in our multidisciplinary clinic, and the one thing that I've learned from him, and particularly for the immunoglobulins, is functional as well as quantitative. So I also do check a serotype 23, 23 valent to pneumococcus to try to get some clues about the functional immunoglobulin response. And then if we start seeing some abnormalities there, think about Pneumovax challenge, retesting, and then I asked Drew to help me with B-cell immunophenotype testing and everywhere from there.
Yeah, no, it's definitely not exhaustive here, and there's tons of other stuff you could order. I kind of just do this as a quick screen. It's like if I identify something, then I send them to the immunologist, like, hey, can you check this and go ahead and do the 23 valent vaccine and see how things go. So any other?
I was just going to say that I've definitely started doing at least the first two, and a lot of the patients that I'm kind of thinking about, is this going to be a biologic candidate in the future? Which biologic am I going to choose? Is this something that I'm going to be thinking about dupilumab up front, or is this maybe something that I would think about mepolizumab or something else, especially with some of the newer data that's coming out about IgE levels and eosinophil counts?
Yeah.
The only thing I would add is, in thinking about this, I always tend to think there's something else wrong here. The normal things that have been done and people are doing are not working. So then this is where we should be looking deeper. And then as you start to see things more and more, it makes you realize maybe we could have addressed that initially as opposed to later in the game.
Yeah, there's plenty of times where I've identified a real low IgG, had them sent, they get on IVIG. It doesn't help them super. I don't know if you guys seen, IVIG doesn't reverse their problem typically, but I think it prevents when I actually go do surgery that now they've got actually pooled immunity, they do better post-op and everything.
The challenge sometimes with IVIG is what they consider an acceptable
range
threshold. I'm like, can we get above 800? And they say, I know you want above 800, and there is data that getting it higher is less sinusitis, but and sometimes I look at these and I think, well, if we know, are we going to be able to change anything? Like the vaccine response, I don't know if you then get someone to get treatment for that. That's what I was going to ask. The
CVID, yeah.
Yeah, for some of those non-IgG.
Yeah, and also sometimes insurance doesn't approve IVIG if they've had a decent 23 valent response, but their IgG is still low. It's yeah.
I think one of the strengths and powers in this too is also helping the patient have, you're able to provide maybe a little bit more context of what you think the direction you may or may not be heading. Maybe you're giving some names to some of the related factors for this. And I think there's a lot of power in that for patients too. It's helping them have a sense of, hey, we're finding progress to better understand what's occurring in myself. And I think that's been helpful. But in terms of the coverage and movement forward, there's a term that relates to additional replacement therapy or whatever it may be. Admittedly, that's, I think, really in the expertise of the immunologist to decide how best to position that with the insurers and the payers.
All right, we're going to, so just a couple of examples. Here's an AFS patient, and you get an IgE serum, and it's 14,000, right? So one of the highest ones I've ever seen. And from my standpoint, remember, IgE only has a half-life in serum about 3 days. And so it's not like this is a comprehensive, oh, yeah, this is how allergic they are. But this patient's very likely to be allergic, right? So they've got a AFS phenotype, and this is what it looks like. But then you look at this guy who, kind of similar picture, not as bad as sinus disease, but has like those fungal concretions, expansion, that kind of thing. And, the IgE is normal, but his eosinophils are high. So this is a good example of kind of, what am I going to do in these scenarios? And the other guy has classic AFS. Is this guy really an AFS type picture? Would he do better on an anti-eosinophil biologic alone versus a Dupixent? So, and then kind of just thinking about what is operative inflammatory infectious sinus disease, right? So the way that I kind of break this up is I think about, okay, if you have disease, but you actually, I don't know if you guys get this, but you get the 60-year-old guy who gets sent in from a primary care for nasal polyps. He comes in the clinic and it's like, oh yeah, I'm fine. I got no problems. There's not 22 is perfect. And you look in their nose and they got grade 4 polyps, right? And there's no expansion, there's no erosion of the eyes, no proptosis. What do you do with that patient? I put them on a topical steroid and they say, see me in a year or 6 months. And so the whole point of this is what are the symptoms? How is that impacting people? Plumbing problems versus topical medication access. So I think of plumbing versus access. Those are the two things that we're going to operate on. And those are like the plumbing problems like recirculation, middle turbinate lateralization. And this may occur in both obstructive and non-obstructive disease, right? But when it comes to access, though, we're thinking about how do we deliver drugs, right? So long history of nasal drug delivery, lots of people putting things up their nose for long periods of time.
How you doing?
Budesonide, right? So we all use it.
Okay.
Back in 2007, Jim Palmer kind of popularized it, and then everyone started doing it. And it's, in my mind, about a molecule of steroid. How can I get it into every single little nook and cranny? And that's the way I think about access. This is just a quick thing, just showing how basically sinus surgery improves symptom scores in high tissue eosinophilia, which makes sense because you can penetrate with drug, right? So you can penetrate with that. And then this little thing showed, this little study showed kind of how ESS is really, the increases, especially with large volume, endoscopic low-through maxillectomy possible benefit. I think this is actually, these extended procedures really do provide benefit for these big polyp patients. I showed this yesterday, just kind of the stepwise ladder for maxillary sinus. I'm going to try and skip some of this from a speed standpoint because we're running out of time and I want to get to some cases. But basically stepwise approaches to bigger holes. And thinking about access, you basically want a big hole. And so that's going to be this upper part of the ladder, ethmoid sinus, plumbing. Plumbing, you start talking about, it's all access. It's all about complete ethmoidectomy, possibly middle turbinectomy. And then the sphenoid sinus, again, upper part of the ladder is the access. That's where you start doing like big hole, unilateral sphenoid drill out. And same thing with frontal sinus. Access is the upper portions. Sometimes a draft 2A, you can get decent access for topical steroids, but that's what we're going to talk about. So case number 1, 20-year-old female, history of GERD, idiopathic gastroparesis. Reports usually getting sick every month, characterized nasal congestion, cough, right-sided headaches. Feeling sick for the last 2 months, treated multiple courses of amoxicillin, steroids, denies allergies or thick drainage, okay? Here is her scan, and let's see, Ian, you want to kind of go over a scan and tell me what you think?
Yeah, so we have a series of coronal non-contrasted CT scans from top left to bottom right. Looks like it's right-sided, varying degrees of opacification, including the maxillary ethmoid frontal. Sphenoid looks to be clear.
Yeah, what is your differential when you have a unilateral sinusitis like this?
Yeah, I always, first of all, ask myself if I'm missing or am I identifying any evidence that would suggest neoplasm or other kind of typically unilateral disease. So odontogenic disease would also be high on my list as well for unilateral disease. So neoplasm, odontogenic disease, rarely you'll see intracoinal polyps on one side of the nose. So I look and screen for that too. And I think endoscopy is really helpful to help further stratify kind of what I'm thinking.
Yeah. So lab work. Get some lab work, and this is it. Immunity looks good, right? So eosinophils look fine. Neutrophils a little high, but otherwise nothing popping out, right? So IgE is 1.1, right? So what are we talking about this patient, right? This is a Th1 type of inflammation in my mind. We don't know the source, and the teeth looked fine. So we always think about odontogenic for unilateral. But this, I think, in my mind, when I was thinking about this, like this is a patient with the classic CRS without polyps, who probably got a bunch of viral infections and just got some persistent infection, and that infection persisted, right? So in my head, I'm not thinking huge hole access here. Is anyone else thinking a big access? What would you guys do in this scenario? What kind of surgery would you do?
That looks like the plumbing problem, like you said. And I suspect, I wish I could see on histology, over infection. Do you just get this like chronic thickening that doesn't resolve? So if you go back to the scan, I mean, at some point you could talk about, do you just take the uncinate off? Yeah. You have to open all the ethmoids on her, but I agree, you don't need a big hole.
I do think there were some nuances in the scan, namely that the auger was clear while the frontal outflow tract was opacified. Yeah. And I think that really kind of goes to that point that it really is a plumbing problem. And I think allowing for that drainage and allowing for some degree of topical medication, at least in the acute healing phase, is really important. So I probably wouldn't go much beyond some anterior sinus surgery. I probably, for her symptom relief, would open up her frontal in that situation as well. Probably not traverse the basal lamella in that situation. And I think I'd isolate it to the right side on that as well.
Yeah.
And these are the people that they will get better from this. You don't have this systemic issue as much as some other patients or some other cases that you could show, where in this case, if you fix the plumbing problem, open things up, are able to deliver topical medications appropriately, they're going to note improvement from this. Yeah.
Yeah, and that was what my line of thinking was. I was going to stick to unilateral surgery. I'm not going to do any big modified or extended frontal procedure. But I want to clean up those partitions. I did do the sphenoid in this case. Some would argue that that was unnecessary. But I was like, I'm sticking to one side. There's a little bit of resident benefit from that too. But so here's the patient, and I've opened everything up. And here they are. I can't remember how long this was. It was probably around 3 months or so. And I was like, they're doing well in the lower sinuses. Oops, sorry. They're doing well in the lower sinuses here. And I did a 2A for the frontal. Hold on. But she's had all these crusting and chronic staph stuff up in the frontal. And in my mind, I was like, wow, man, did I make the wrong call here? Is this an access issue? I decompress it a couple times in clinic. The hole looks fine, but she continues to have some chronic infection in this region. And in my mind, I've treated her a couple times with a short course of antibiotics, not getting better. Going back to that lab work, right? Th1 type phenotype. This is the type of patient I'm thinking a nice long course of azithromycin or Biaxin is another option. But this patient, I was like, let's see if she tolerates azithromycin. She actually did tolerate it even with the gastroparesis. But and here she is, 3-month course of azithromycin, and this is really what cleared her up. And I was never a big, azithromycin kind of for all these patients. But I think with the phenotyping and the way that we look at the patient, this was an appropriate. Oh, where is it? Sorry. 3 months. There we go. Yeah, that's the next step. So here is her 2A after 3 months of azithromycin, and now I got her cleared up. She did not require anything further after this point. So this was a really good illustration for me. Th1 type phenotype. Azithromycin actually worked very well. Yes.
Was she symptomatic from that?
Yes.
She was feeling that.
Yeah, she was feeling the frontal pressure. That's right. All right, let's see. Oh, man. Don't have much time for this, but 41-year-old male, significant CRS, seasonal sneezing, itchy watery eyes, anterior posterior nasal drainage, previous 4 fesses, compliant with budesonide rinses, lots of green crusts, allergy testing, allergy shots. Outside physician has done a number of different surgeries, still some residual partitions and whatnot. Let me show you what this looks like. I put him on some triple rinses, which he had decent access, so I didn't operate on him up front. but still like this pooling in the sinuses and whatnot, right? So lab work. Here's the question. So culture positive for Pseudomonas MRSA. So what is your next step? Surgery, if so, what type? Biologic, labs, antibiotic rinses. Sorry, I skipped ahead of the antibiotic rinses, but tell me what you would do in this scenario. Would you go ahead with surgery? Or
I would definitely want to get some labs up front. I mean, I definitely with the Pseudomonas, I have a high concern for immunodeficiency. I think this is a good patient to get a CF screen on, and so I would definitely proceed with that. I think I think when you're looking at what the utility of further surgery is right now, I mean long term, yes, maybe they'd benefit from a right-sided endoscopic medial maxillectomy. They might benefit in getting some better access with a frontal sinus drill out. But I think at this point, they really want to get a better understanding of what the reason is that this patient isn't getting better with the surgery that they've had.
And that's exactly right. And in this scenario, this is 2018, and I didn't really start doing routine lab work until around late 2016, early 2017, and so this is a perfect example. I actually had done a CF genetic screen, and he came back heterozygous for F508del. And I was like, well, this could be CFTR-related disorder. It could be, and so I got a sweat chloride afterwards, and he had kind of a intermediate level. And as you know, that can be kind of indeterminate, but it can be CF. And actually, when they did a full sequence of his genome, found another mutation on there. And so this guy had mild CF, and he's 40-something years old and just went under the radar. And as you know, we have these awesome CFTR modulators nowadays, and what these things do is they allow in a F508del mutation, which is 90% of the CF population, allows the protein to get to the cell surface. Then what they do is so that's actually normal CFTR. But so what normally happens is the protein gets degraded, but they have these little modulators that help protein get to the cell surface, and then they potentiate the channel, allow chloride channel opening, which basically restores a lot of their CFTR function. And so all we did to this guy was send him to the CF clinic, and he actually is doing absolutely fantastic. I never did any more surgery on him. I keep going back to the wrong video, don't I?
Looks great.
Yeah, it looks great. That looks fantastic. So in this case, he's got a little bit of stuff in the left maxillary, but everything is now clear. His frontal sinus looks great. Just a little bit of cleaning that left maxillary. I actually just recently saw him, and he looked fantastic. This is his scan, which I was like, I just want to get a scan, see if there's any sort of obstruction or anything. And this is just using a CFTR modulator. It's absolutely amazing. So just goes to the point, sometimes you don't need to do surgery. Sometimes they do well. And time's up, man. Only 2 cases.
Those CFTR modulators, it's really an incredible drug. I mean, I think if anybody, it kind of, when you read about them, it's kind of like science fiction. It's kind of incredible.
It's amazing.
That we could have created those.
I was talking to Sanjay about this yesterday, and it's like literally, I operate on a CF patient once a year now, and in the old days, it was like, you do a big surgery and then you have to debride them and they come back to clinic. And a lot of my patients they come back once a year now. So you don't even need any debridement. It's pretty fantastic. Sorry, I ran out of time.
We'll leave this case as a cliffhanger for next time Brad comes to Seattle. But great panel. Thank you, everybody.